Morning. We're going to get started here. So today's speaker is Jeremy Van Hoff. He's currently the Chief Fellow at the University of Minnesota for their Cardiovascular program. And Jeremy went to med school in Loma Linda and did his internal medicine residency at the University of Minnesota and went on to fellowship there as well. Has his master's in clinical science and has interest in prevention and PAD as well, which is what he's going to talk to us about today. And ironically, we're both from the same small town of Edgerton, Minnesota. And in classic small town fashion, he's the brother-in-law to my sister's first cousin. So he's going to talk today about PAD. Jeremy?
Thank you very much.
I have clinics when I leave, it's not really talk bad.
All right, thank you. All right, thank you guys for inviting me and for everyone coming out this morning. We are from a small town. We're not all related, but we can find a way to relate most everyone there. So the topic I'm going to talk today is about cardiovascular disease prevention, and then with a focus on peripheral artery disease. And I titled it "The Leg of the Window to the Heart." So I don't have any conflicts of interest, but there's some research here that was supported by a grant from Merck, none of which I benefited or compensated from. And there's some slides here I used that were developed by the Minnesota ACC. So we'll start by talking about peripheral artery disease, some epidemiology, talking about the prevalence of the disease, some risk factors for PAD. We'll talk about screening, we'll talk about some therapy options, and we'll talk about the cardiovascular and limb event rates associated with PAD. So I can't do a talk in the Twin Cities without mentioning Alan Hirsch. I'm sure anyone who's seen patients with PAD have thought about Alan or have read his research or the guidelines that he's co-authored, so I can't go on without mentioning him as well. But most people, when they think about PAD clinically, and when they think about patients, these are the images that come to mind. And obviously, these are very advanced cases of peripheral artery disease. This is in critical limb ischemia territory. And as clinicians, what we really want to do is prevent this from happening. How do you find these people before they show up in your clinic with a foot that looks like that? So most of PAD is atherosclerotic disease, like disease in other vascular beds, like coronaries, which typically we're more comfortable with, or stroke. The majority of the disease is caused by cholesterol plaques forming in the arteries. And similar to other atherosclerotic disease in other territories, the risk factors for PAD are similar. So looking at a couple of, this is just a more recent clinical trial, because it's a COMPASS trial where they looked at low-dose rivaroxaban in people who have atherosclerotic disease, including PAD. On the left is the overall trial. So this includes PAD, coronary disease, stroke. And on the right is the characteristics of people who just had PAD. So just to compare a little bit between atherosclerotic diseases, you see that people with PAD in the trial population were a little bit younger. They had a little bit worse control of their blood pressure. These are trial patients. And there's a higher prevalence of smoking, 27% in the PAD population, 21% in the overall population. And they had more hypertension, they had more diabetes. So this is looking at the clinical trial population, the risk factors. Looking at risk factors in a community population, this is from the REACH registry, which is an international registry, where they collected patients with coronary disease, stroke, PAD, and multiple risk factors for atherosclerotic disease. And here you see there's some differences in diabetes. Diabetes is more prevalent in the PAD population, and smoking is more prevalent. Some of the other risk factors like hypertension and high cholesterol are relatively similar between the PAD and the coronary disease groups here. So looking at PAD in the community, it's a common disease. So this is a nice slide that kind of outlines different studies in different communities looking at the prevalence of PAD. So starting at the top, looking at an NHANES population, just looking at adults over 40, PAD was found in about 4.3% of patients. And then as as you go down and you look at different ages and the age cutoff goes up, you see that PAD becomes more common. And then finally at the bottom, you have the age cutoff of over 70, and then you add some risk factors in like diabetes and smoking. And when you add risk factors, the prevalence of PAD can go up to nearly a third of patients that they screen. So a highly prevalent disease in the right high-risk population. So how does it compare to other cardiovascular diseases that we're maybe more comfortable or more used to seeing? Atrial fibrillation in the United States, estimated about 4.2 million. PAD in the United States estimated to be present in about 9 million patients. Heart failure, about 6 million versus the 9 million. And global estimates of PAD are as high as 200 million people. So it's very prevalent both at home and internationally. So a few other characteristics of people who have PAD. This graph has this figure has a lot of information in it, but if we just break it down to men on the left, women on the right, and then age on your x-axis, you see that in men, the inflection really starts at around 60, and once you get over the age of 70, over 20% of African American men have PAD. And when you look at women, that inflection point starts again around 60, but the scales are a little bit different, so the prevalence doesn't reach 20 until beyond 70 to 79. And in both men and women, you see that the rate of PAD is doubled in African Americans. And in Hispanic women, it's also similarly elevated. So despite the frequency of PAD in the general public, it's an under-recognized disease. So this is a study that Alan did back in the 90s where they screened people at high risk for PAD. And again, going back to that other bar graph is people over 70 or 50 to 69 who have risk factors, essentially. And they estimated that using that criteria, they would find about a prevalence of 15%, when they actually found was 29% of those that they screened had PAD. And almost half of them were newly diagnosed with PAD. And of those who had PAD, known PAD, 82% were able to say that they had PAD, but only half of their physicians, when surveyed, recognized that they had the disease. So a very prevalent and under-recognized problem. And why is that? Why do you think that we can't pick it up if it's so prevalent? Why can't we pick it up faster or better? And I think this graph is a big reason why. So claudication is kind of the classic symptom of PAD. When you have calf pain after a certain distance of walking, that relieves, it goes away with rest and comes every time you walk. That's a classic claudication symptom. And only 11% of the people screened in the Partners trial had classic claudication. A third of them are asymptomatic, so those people are very difficult to find. But just a little over half of them had atypical leg pain. This could be pain that came with rest or with activity, or it could be back or hip pain, but it's just not it doesn't fit a classic claudication picture. And that's a harder population to pick up, especially because, again, this is an older population. So having knee pain, for example, is a common complaint in the elderly. So how do you recognize a joint problem versus a claudication problem or a ischemia problem? And so it gets very difficult. So how then do you diagnose PAD? If symptoms are not the way to do it because only 10% of them present with the classic picture that you think about with PAD, then that's not a good way to pick up PAD. Physical exam could be a way. On physical exam for PAD, you check their feet, you look for sores, you look for dependent rubor, so when the leg is down, it will become red. When it raises up, it turns white because you're not getting enough blood flow. Pulse exam, if you have pulse deficit, that can tell you, give you some indication that there's not enough blood flow to that limb. But all that takes a lot of time. And you can imagine in Minnesota winter when someone comes in with their knee-high boots on and they're all laced up, and most of these people are coming to a primary care physician, and they have a 15-minute visit, the feet sometimes get overlooked. So physical exam, I would argue, is not a very great way to pick up PAD. So then you're left with screening high-risk individuals. So that brings us to the PAD guidelines. They were most recently updated in 2016, and they talk about who to do testing for to detect PAD. And the test of choice for PAD is an ankle brachial index. So you take blood pressures in the arm, you take blood pressures in the ankles, and you look at that ratio. A ratio that is less than 0.9 is indicative of a flow problem. So in the guidelines, they say they give a class 1 indication for people who have symptoms, classic symptoms, or their history suggests PAD, or they have a physical exam finding that suggests PAD. And we said both of those are not great ways to figure out who has PAD. So what they also provided was who may be at increased risk for PAD, where you might decide to do an ankle brachial index. And this is the list of people that they came up with. And you'll see some of these age targets and risk factor targets that were mentioned in Partners Trial and some of those other community-based studies. So anyone over 65, if you look at people who are 50 to 64 and they have any risk factor for atherosclerosis, any of the classic risk factors, or they have a family history of PAD. And then even if they're less than 50 and they have diabetes and an additional risk factor, all of those people are estimated to have a prevalence of PAD of at least 20%. So if you're doing ABI testing in this to 1 in 5, you would expect to have a positive result. So if you're looking at screening, a pretty good target. So the AHA and ACC gives us this a 2A because there are no clinical trials that look at screening exactly these populations. And we'll come back to screening in a little bit. So as I said, most of these patients are not coming to the cardiologist's office, and many of them, or the majority of them, are going to be seen by primary care physicians. So it's important to look at the recommendations, the guidelines that are more focused, are more used by the primary care community. So United States Preventive Services Task Force is one of those bodies, and what they gave screening for PAD is that they gave an I recommendation, meaning that there's insufficient evidence to do screening. And the American Academy of Family Physicians also usually aligns themselves pretty closely with USPSTF. So along with them, they also say there's insufficient evidence for screening. And some of the things that USPSTF cites is that there are limited data that ABI testing changes outcomes. And that's true. There's no clinical trial where until recently, where they would do a screening of ABI just broadly and then see how the outcomes change in those patients. We are getting some data for that, and I'll show that in a little bit. They also say you need to address the population at risk who are undertreated. So they argue, you saw the list of age and risk factors, they argue that most of those people either have another comorbid atherosclerotic disease that requires treatment with statins and aspirin and blood pressure, diabetes control, all those things. So adding a diagnosis of PAD doesn't change their management, which is true. And even if they don't have a comorbid atherosclerotic disease, they have enough, most of them have enough risk factors that they would meet thresholds for treatment. And then finally, they say most people with PAD, oh, sorry, that's what I said earlier. So most people with PAD already have an indication for preventive therapy. So they're saying some more testing needs to be done, focusing on people who are undertreated and at high risk. So this is the one clinical trial that we have that looks at screening for PAD, among other things, and then looking at outcomes. So this is a Danish trial. It's the investigators screened 50,000, or they enrolled 50,000 men between the ages of 65 and 74, and they screened them for abdominal aortic aneurysm, peripheral artery disease, and hypertension. So they did all 3 for these people, and then they followed them for a median of about 4.5 years. And what you can see, there are 2 lines here. They are very close, but with the high number of people that they enrolled, they did see a statistically significant difference in outcomes. And here on the y-axis is survival. So it's a very important outcome. And this translates to about a 0.6% absolute risk reduction in death over 4.5 years. And that translates to a number needed to invite. This isn't how many they screened, this is how many they invited to participate. A number needed to invite of 169 people. Now, to put that into perspective a little bit, for breast cancer screening, the number needed to invite to prevent a death due to breast cancer is about 500. So it's not the most impressive separation of curves, but this is a mortality benefit, and it is a non-invasive screening. There's more details about this trial. You know, one of the side effects of screening is a false positive test, over-treatment, over-diagnosis. But the only thing that they saw in this trial is the people who were screened had more surgeries for AAA. Otherwise, no other invasive, no increased invasive procedures. So the reason, this is extrapolating the data a little bit, but what they saw in terms of medication use in those who are screened is, again, the screened population is in red here. Those who are screened had an increase in antithrombotic medications, lipid-lowering medications, and antihypertensive medications. That was seen in the first 6 months of the trial, and then from 6 months on, there was no difference. So when they got those initial results, the patient's physicians saw and decided to treat their patients. And this is, again, this is a little bit of extrapolation of the data, but presumably this higher intensity of preventive therapy is the main driver of the reduction in events in the screened population. So moving towards what are the guideline-based treatment options for peripheral artery disease? And these are coming from the ACC/AHA guidelines, those 2016 guidelines. I'm not going to spend a lot of time on medications. That's an entire talk of its own. But the class 1 indications for therapy are statins for PAD, smoking cessation, antiplatelet therapy, and then ACE inhibitors receive a 2A recommendation. And then supervised exercise I put on there because after the guidelines were published, supervised exercise became funded or reimbursed by CMS as a therapy for people with PAD and claudication. So just to briefly highlight some of the trial data that supports these recommendations for therapy. The heart protection study is one of the biggest trials that that we have to help guide therapy for PAD. And it was a trial that enrolled people who had different cardiovascular disease, but they pre-specified some of these subgroups. So you see that PAD patients had a similar benefit from statins as stroke patients and coronary heart disease patients. Smoking cessation is always a challenging intervention to monitor, as it's not you can't randomize someone to smoking. So you have to see what happens if someone stops smoking and then follow them over time. So most of this is observational data, but this is a very nice trend where you see reduction in events the longer someone is from their last cigarette. So a very nice dose response in outcomes in smoking cessation, supporting the recommendations. Antiplatelet therapy is a tricky subject for PAD. This is a meta-analysis from 2009 that you can see way down here at the bottom. This is the final, and it just crosses the the 1.0 line. So there's a trend towards improved outcomes with aspirin therapy in PAD, but you can see also that there are data points on either side of the line, and most of them are very close to the line. So there are previous meta-analyses that do show a statistically significant benefit. There are some sub-analyses that show a benefit for stroke outcomes. This is the MACE outcomes, so total cardiovascular outcomes. For now, it still has a class 1 indication in PAD. And as I said, aspirin alone could probably be an hour talk on its own. So I'm not going to go into too many details of that one. And then finally, the data for using an ACE or an ARB in PAD primarily comes from a subgroup analysis of the HOPE trial, where patients on ramipril were shown to have better outcomes, MACE outcomes, than those who were on placebo in the PAD subgroup. I put these all up there to emphasize the fact that we don't have a lot of data in clinical trials for PAD, especially historically. There are a number of more recent trials that I'll highlight a little bit later that did a much better job of specifying a subgroup of PAD, a pre-hoc subgroup of PAD, and they were able to make, have a better, I think, conclusion based on that data than some of these older trials where it was a lot of post-hoc analyses and subgroup analyses. But in general, like the clinical world, in the research world, PAD has kind of been ignored for a number of years. And then finally, the supervised exercise. So this is a study that compared optimal medical therapy in people with PAD, that's this light blue line, to those who, and these all had claudication, to those who were treated with a stent in red or supervised exercise in green. And this is claudication onset time. And then the y-axis on here is the peak walking time. So you see that supervised exercise performed as well as stenting for claudication symptoms and outperformed for peak walking time. There are some other quality of life measures that were included in this trial. And for the quality of life measures, actually, the stent outperformed supervised exercise in many of the questionnaires. So how good are we at prescribing even these 3 or 4 preventive therapies in PAD? And the answer is not very good. So the top bar here, this is NHANES data. The top set of bar graphs here is statin use. In the red, this is PAD with cardiovascular disease. So this is people who have other comorbid disease in some other vascular bed. And they, in NHANES data, were taking statin about 58% of the time. If you had PAD and no other disease, it was less than 20% were on statins. And this is published in 2011 in data 99 to 2004. ACE-ARB, worse, about a third of those with PAD and comorbid disease, and again, about 20% of those with PAD only. And then antiplatelet use had the highest prevalence in PAD with other disease, and about 27% of those with PAD only. So vastly undertreated when PAD is present on its own. Here's another population. These are patients in this study by Meltzer who are undergoing treatment for symptomatic PAD. So these are people who have disease that's symptomatic such that they are now going to the OR or the catheter suite to have a revascularization procedure. And even in these people who are near the last ditch of trying to save their limb, are only 59% of them were on a pre-op statin, and about 80% of them were on an antiplatelet of some sort. And the authors looked to see what could predict who was on appropriate therapy, and it wasn't the risk factors for the most part, although hypertension did predict being on a statin a little bit, But the biggest predictor, again, in this group was did they have disease in some other vascular bed. So for some reason, we are very good at getting people to take their medications when it's coronary artery disease or stroke, but we're not so good at getting people to take them when it's peripheral artery disease. And you might ask, and again, we don't have a lot of clinical data for some of these medications, but we do have observational data. So here's some observational data looking at people who underwent endovascular intervention for claudication. So here's symptomatic PAD again. And of those who are on all 4 guideline therapies, so statin, antiplatelet, ACE inhibitor, and were abstaining from smoking, how did they do compared to those who are on less than 4? And you see in the blue line, these are those who are on all 4, and then the red is less than 4. And in this graph, this is a major adverse cardiovascular events. This is traditional MACE. And hazard ratio for being on all 4 is about 2/3. So 2/3 of the events in those who are completely treated versus those who are undertreated. For death alone, it was nearly, the mortality rate was nearly half in those who were completely treated. So profound reduction in events when we can get people on all the right medications. So there are a number of newer medications beyond some of these guideline recommended therapies, and one of the ones I wanted to highlight because I think we'll be seeing more and more from about this topic is the COMPASS trial, which looked at low-dose rivaroxaban in addition to aspirin or low-dose rivaroxaban alone versus aspirin monotherapy. And the original COMPASS trial was people with atherosclerotic disease, and they had over 20,000 people, but they had a 7,000, almost 7,500 people with PAD only, both symptomatic and asymptomatic disease. And they did a subgroup, pre-specified again, subgroup analysis of this population. You can see that those who are on rivaroxaban and aspirin had a nearly 2% reduction in MACE, which is the primary endpoint for the study, with a statistically significant hazard ratio of 0.72. So over 25% reduction in MACE events in those who are on this low-dose rivaroxaban. There was an increase in bleeding risk between rivaroxaban plus aspirin versus aspirin, so that does have to be weighed, but it was a smaller degree of bleeding than we see in the reduction of the cardiovascular endpoint. Similarly, limb events is an important event in people who have PAD, and you see even more profound reduction in events in the rivaroxaban plus aspirin group for limb events. So this is total major adverse limb events here, and you had about a 1% absolute risk reduction between the rivaroxaban and aspirin group versus aspirin, which is nearly a 50% reduction, relative risk reduction. Amputation rates were low, but again, you see a statistically significant decrease in amputation in the rivaroxaban group. So although this study came out after the guidelines, I think that for the next iteration, this will be very likely make it into the next round. So the beginning of the talk was the legs of the window to the heart. So I know we've been talking about PAD and the legs are not the heart, but I think you've seen that the outcomes that are important for people with PAD are cardiovascular outcomes, are heart outcomes that we're used to seeing, more used to seeing. People don't die necessarily from pain in their leg. What they die from is a heart attack or they die from a stroke. So to emphasize the risk of these outcomes in PAD patients, I wanted to highlight just a couple of these newer trials where they did have some pre-specified subgroup analyses in PAD patients. This is one that looked at ticagrelor. It's the Pegasus trial. And we can just look at the placebo groups. So these are the people who are on aspirin monotherapy. And here's the PAD group. with a 3-year event rate of MACE of 19% versus those who did not have PAD of 8%. So all of these people in the trial had prior MI, but the PAD group had over double the cardiovascular endpoints of the non-PAD population. Similarly, this is a study looking, this is a subgroup analysis of the Fourier Trial, so looking at PCSK9 inhibition. And you see a very similar story here. So again, just focusing on the placebo group, you have a primary MACE endpoint here of 16.8% after about 3 years in the PAD group, and only 12% in the non-PAD group. So even though this is a disease that's in the legs, by definition, the problems that these patients experience affects much more than just their legs. So this is that's clinical trial data. What about more community-based data? So going back again to the REACH registry, this is the international registry again, looking at people with established cardiovascular disease or risk factors. So in this registry, 12% of the patients that they enrolled had PAD. If you look at the top line, the all-cause mortality, and this is 1-year event rates, was 3.8% in PAD. Higher than stroke, higher than coronary artery disease patients. Now, and most of that was cardiovascular death, 2.5 in PAD versus 2 and 1.9. MIs were more common in coronary artery disease as you would expect, and strokes were more common in the stroke cohort as you would expect. But when you look down at limb events, again, as you would expect, the rates of bypass grafting or revascularization were much, much higher in the PAD subgroup. That's the REACH registry. Then looking a little bit closer to home, we did some work with some Medicare data, looking at event rates in PAD patients. So we had a 20% sample of Medicare's Parts A, B, and D from the years 2011 to 2014. And in that time frame, we found nearly 700,000 people with PAD. And we followed them up until the end of 2014. And here's some of the results for MACE. So this is in blue, this is major adverse cardiovascular events, and in orange, this is just death. So looking at the total PAD cohort, total MACE was about 18% per year, and just death was about 14% per year. This is an old, again, this is Medicare, this is an older population, median age is about 78. But it's a dramatic outcome in patients that we see very often. You can see that there are certain risks, there are certain groups that are higher risk. Obviously age especially plays a part in death. And then other highlights are Native American populations have higher rates of death, and males have slightly higher rates than females. Moving on now to non-fatal cardiovascular outcomes. In gray, you have myocardial infarctions here. In yellow, you have stroke outcomes. So when you exclude that high competing risk of death, you still have pretty high rates of MI and stroke in this elderly population. So in the total cohort, the rate of MI is 2.5% per year, and the rate of stroke is 1.5% per year. Again, Native Americans have a higher risk of MI, and stroke rates are pretty similar by race. And men have a higher rate of MI and similar stroke rates to women. And then if we look at limb events, a very important factor for PAD patients in terms of quality of life and in terms of risk of future risk of death after a limb event, which I'll show in a little bit as well. So in the total PAD cohort, limb events were 3.3% per year. So compared to a cumulative non-fatal ischemic cardiovascular event rate of around 4. Limb events were not far behind, 3.3% per year. So an important outcome to keep in mind both for clinical guidance and also for design of clinical trials when you're involving people with PAD. The limb events were dominated by revascularization in the dark blue, and amputations were low in this group, about 0.3% per year, and acute limb ischemia is about 0.5% per year. So how does that Medicare data line up with some of the clinical trial data? The Medicare data here is this pink one on the left, and we'll highlight here all-cause death dominates in Medicare data. So again, the patient population in the Medicare data is at least about 10 years older on average, but also clinical trial, when they enroll people with all the exclusion criteria, often will weed out some of the sicker patients. So I think that explains some of the big difference here. But it also cautions some of the extrapolation of findings in these clinical trials to real life and Medicare patients with PAD. Beyond that, the MI rates and the stroke rates are right in the same ballpark as you would expect, or as we saw in the clinical trial. For limb events, the individual limb events in some of these clinical trials are a little less granular, but you see acute limb ischemia, again, kind of in the ballpark of some of these other clinical trials. This TRA2P was for Vorapaxar. This is Pegasus, again, ticagrelor. Euclid is a ticagrelor study, and Fourier, again, was the PCSK9. And limb revascularization rates in the Medicare population was a little bit lower than we saw in some of the healthier clinical trial patients. So I mentioned that limb events are important for long-term prognosis, and that's highlighted in this table, where you see people who had a previous amputation or previous revascularization in our cohort had a much higher, especially for amputation, had a much higher risk of death. So here's the annual death rate in the population who had a prior amputation, 34% per year. And for those who had a revascularization, not as high, but higher than the total PAD cohort. And as a comparator, looking at a non-PAD cohort, death rate of 3.4% per year. This is age adjusted. So the final thing we wanted to look at in this Medicare data was what happens to people who are diagnosed when they come into the hospital versus when they're diagnosed in the clinic. And the thinking behind this is, how can we shift diagnosis from hospital to the clinic? And I think that has to do with screening ABIs. So this is a kind of a summary slide of outcomes in those in purple who were diagnosed as an inpatient and those in yellow who entered our cohort in the outpatient setting. So on the top left, this is death. And you see that risk of death is double for those who are diagnosed as inpatient. And this is adjusted for age, sex, and comorbidities, risk factors, everything that we could kind of think that would raise your risk of death we use in the model. And of course, you see that the biggest risk probably has to do with the hospitalization event for death, but for these other non-fatal event rates, this is myocardial infarction or stroke, this one is total limb events, and this is a total non-fatal ischemic event rate. All of three of these graphs continue to diverge well past the acute kind of risk of hospitalization. So again, indirect evidence, but I think evidence to suggest that if we can diagnose people in a stable outpatient setting and put them on appropriate therapy, that we may be able to turn kind of the flatten the curve here. So to summarize what we talked about today, peripheral artery disease is a highly prevalent disease. Diagnosis of PAD is associated with elevated cardiovascular and limb events, which is why we really need to pay attention to it. Patients with PAD do not receive adequate preventive therapy compared with other atherosclerotic diseases. And finally, appropriate screening in high-risk populations has a high yield and may improve outcomes, but more evidence is needed. So I just want to thank some of the people I've worked with. We've had collaborators from the University of Minnesota and from Colorado, from West Virginia, and from Tennessee. And of course, all of this was started by Alan Hirsch, and hopefully we can continue it in the integrity that he would like. So with that, I'll take questions and leave this map. This is a heat map of sorts. So this is using that Medicare data and using a youth spatial program at the University of Minnesota. We actually partnered with a grad student from the geography division to create this map. And this is PAD prevalence across the country. So the darker the purple, the higher the prevalence.